So I've been asked to do this sort of introduction to Lynch syndrome. As John said, if I say anything you're not sure about, just give me a shout and I'll try and explain stuff. But essentially, if you Google the definition of Lynch syndrome, this is what you get from Dr. Google. So it's an inherited genetic condition, significantly increases the risk of colorectal cancer, endometrial cancer and a number of other cancers. It's caused by mutations in DNA mismatch repair genes, and it's an autosomal dominant condition. That's pretty accurate. It's just trying to work out what some of that means and where this has all come from. So there was a family described by author in 1913. This was his seamstress who had said to him, my family's has died of cancer, I'm going to get cancer. And she did indeed get a gastric cancer. So this family was first described in 1913. And then in 1971, a doctor in the States called Henry Lynch went back to that family, updated the family tree, and there were lots of other cases of cancer in that family, and published it under what he called then the cancer family syndrome. And subsequently to that, there have been a number of other cases of families published. Some had predominantly colon cancer, some had other cancers. So another doctor described those, but decided that because Henry Lynch had described this massive family, that actually we should call them after Lynch, and there'd be Lynch syndrome 1 for the colon cancer and Lynch syndrome 2 for the colon plus cancers. And over time, it became fairly obvious that these were actually the same thing, but just different manifestations of it. The decision was made that we would call this hereditary non-polyposis colorectal cancer, or HNPCC, because that differentiated it from some of the other inherited predispositions to bowel cancer, where you got lots and lots of polyps, so the familial polyposis type syndromes. And then in 2005, it was decided that because that name suggested it was just colon cancer, and clearly there are a lot of other cancers associated with Lynch syndrome, we should go back to calling it Lynch syndrome. And that is the definition of the condition caused by changes in genes or the mismatch repair genes. So what you will see historically is this one condition has been called a lot of other things. And certainly one of the things we noticed that when we were a couple of years ago putting patients into the National Bowel Screening Programme, patients were getting letters saying, you've got this condition, you're now having your screening in the National Bowel Screening Programme. And a couple of patients phoned us up and said, I haven't got Lynch syndrome, I've got HNPCC. So I think it's just that, these are patients we'd seen 20 odd years before, and it's just making sure that if you see anything in the literature, it's the same thing. It's just had a number of names over the years. It is caused by mutations in the mismatch repair genes. The other gene that you'll see mentioned sometimes is something called EpCAM, which if you have a fault in that means that MSH2 doesn't work properly. But these are the different mismatch repair genes on different chromosomes. So when we're talking about mismatch repair genes, if you look at a cell and you look at DNA, when DNA replicates, what happens is your strands of DNA separate, and then you've got this whole mechanism in the body where you come and basically generate a new DNA strand. But it's very specific. So where you've got in this diagram the two greens going together and the red and the yellow going together, that's how it should be, because you've got your bases that match. So you C and G and A and T always match. So that's the way that replication is supposed to happen, is you've got the separating of the strands, and you've got a mechanism that goes in, and you make sure that on your base strand, on your sort of master strand, you then replicate to the right base. But that doesn't always happen, right? So what you will get is what we call mismatch repairs. So in the top one, I'm sure if you can see, rather than having a C, you've got a T, because the mechanism's just not worked properly. Or you can have it where actually the replication strand, there's a little bit of a kink in it, and you get the wrong bases. And they are called mismatches because the replication hasn't happened properly. There's then this whole complex of proteins that come along and say, well, that's wrong, let's cut that bit out, and then we can create a space for the right enzymes to come in and do that process again and repair that mistake. And they're the mismatch repair genes. And if you look at those proteins, they're MLH1, MSH2, MSH6, and PMS2. And that's the process by which you have the repair of that DNA error. If you have a fault in those genes, which is what happens in Lynch syndrome, then those errors don't get repaired. So what you have within a cell is an accumulation of mutations or mistakes in different genes, If you get enough of those, you get to the stage where you get abnormal cell growth. So that can come up with abnormal polyps or potentially cancers. And that is essentially why with Lynch syndrome you get an increased risk of these cancers. And depending on which gene, you get a different rate of cancers. And I'm not going to go into this in too much detail because Terry's going to talk about this for the next talk. I think the one thing I would want to mention about this is that this is data from an international collaboration. And what you can see is with PMS2, when these figures are what we call confidence intervals. So basically how accurate we think this data is. And these confidence intervals in PMS2 are massive because we don't think the data is particularly accurate, because we know with that cohort of patients, actually there weren't many cases of PMS2 in that cohort. And that's because probably until about 8 years ago, we weren't really testing PMS2 because technically it's really difficult to do. So it's just saying that some of the data we get about risks is likely to change over time as we find more information. The diagnosis of Lynch syndrome, traditionally we did it through a family history. So if someone came to clinic and they said they've got lots of people in the family with cancer, we'd wonder whether this is the condition and do investigations. But that's actually pretty inefficient, because in order to get that diagnosis, this is something called the modified Amsterdam criteria. And what you needed to have to be able to say you had a clinical diagnosis of Lynch syndrome at that point is to have at least 3 people in the family with one of the, it's called HNPCC at that point, Lynch-associated cancers. They had to be related to each other, so they had to be first-degree relatives to each other. And one of them had to be diagnosed under the age of 50, and they had to be over 2 successive generations. So actually, that's a really high bar to say this family have got Lynch syndrome. And these criteria were drawn up less about a clinical diagnosis and more about identifying families in whom we could do the research to try and identify the gene changes. But historically, it ended up being a sort of hangover that you needed to get to this family history to have this diagnosis, or a significant family history to then have an investigation. And this is the sort of family history you'd see, people who had young ovarian cancers, young endometrial cancers, or young bowel cancers. And this actually, you look at this family tree, pretty obvious that this family have got Lynch syndrome. But this is not typical for a lot of families that we see. So because of the issue around diagnosing Lynch syndrome and the fact that we know that quite a lot of patients don't have a really strong family history, there were a couple of committees set up with NICE. So this is the National Institute for Clinical Excellence. And the first one was looking at whether we should be testing all cases of bowel cancer at the point of diagnosis to see if there's potential evidence for Lynch syndrome. And then the second one is around doing the same thing for endometrial cancer. And those recommendations came out in 2017 and 2020. And what that was saying is that you should, at the point of diagnosis, do a test to see whether there needs to be further investigation around whether a patient has Lynch syndrome or not. This is the pathway that we've got in the Northwest. So essentially what we are saying is that if a patient has a new diagnosis of colorectal cancer, and it's fairly similar if you have a new diagnosis of endometrial cancer, that tumour should have immunohistochemistry, so staining for the mismatch repair protein. So the genes produce a protein. If you look at a tumour, you should be able to stain for those proteins. And if those proteins are present, it suggests the Lynch syndrome isn't likely. If the proteins are absent, it suggests that you need to do further investigations on that tumour or on that individual. And you can also do another test called MSI, which is the same sort of process. So that's the first step in this diagnostic pathway, that if you find an abnormality, you then go on to investigate. Not everybody who has a change in their cancer, which suggests Lynch, has Lynch syndrome. So the downstream testing is really important. And certainly one of the things that we are seeing a lot of now is that a patient with a cancer gets investigated. This first bit of the test's done, and then suddenly everybody else in the family comes in saying, well, we think our family member's got Lynch syndrome. But actually, when you do the downstream test, we manage to exclude it. So actually, a diagnosis of Lynch syndrome is dependent upon not only the testing on the tumour, but all the other tests. And then the final test is the blood test to look at the actual genes. But this means that you are getting to a stage now where, in theory, in 20 years' time, we should be picking up all the cases of Lynch syndrome at the diagnosis of the cancer. Now, hopefully, we get to the stage where we've identified so many families that we're not getting the cancer diagnoses. But that's the process we're in at the moment. So you can diagnose it through a family history. You can diagnose Lynch syndrome through what we call reflex testing, which is that first test of the cancer with either endometrial cancer or colorectal cancer. One of the other drivers around this testing of all the cancers is that there are drug therapies that are really useful for people who have tumours that have abnormal mismatch repair. So there is a drug for bowel cancer called checkpoint inhibitors. And it was really clear for some early studies that if someone had a very late stage bowel cancer and their tumour showed that their mismatch repair was abnormal, they responded really well to these drugs, much better than people who had normal mismatch repair in their cancers. So that's been another driver for trying to look for this in tumours, is to see whether it can then direct therapy, whether we can give people these particular drugs. So that now there are other tumours in which they're doing this sort of immunohistochemistry or MSI, mainly to direct therapy, but one of the knock-on effects is then we may diagnose Lynch syndrome because of that. The other thing that's becoming more common now and is actually quite difficult to deal with is that we can find Lynch syndrome as what we would call an incidental finding. So there are lots of genetic tests being done for lots of different conditions in the population. A lot of those tests, as part of the test, will look at a whole load of genes, and a number of those are the cancer predisposing genes. But it means that we are now getting diagnosis of Lynch syndrome in people who are having a genetic test for a completely different condition. So for a neurological condition, or for children who've got developmental disorders. And then we are finding, as a byproduct of that test, that individual has got Lynch syndrome. That's really quite hard for people to get their heads around, because it's not a test that was supposed to be done to look for the condition. It doesn't explain the condition that person has, but it's an incidental one, and then the knock-on effect of making sure that individual gets into the screening programme, and then we do cascade testing and talk to the rest of the family. So that can be really hard. It's particularly challenging if you've got a young child with a developmental disorder to talk to the parents about the fact that we found something in their genetic makeup which has nothing to do with that developmental disorder, but will affect that child when they're older. And that can be really a challenging conversation to have. But it does mean that we are finding patients with Lynch syndrome in a variety of different ways. So anyone who has a new diagnosis of Lynch syndrome, whether that's been diagnosed because of their cancer or it's been diagnosed in a different way, should be seen in the regional genetics service. So what we often see is patients who have a colorectal cancer and endometrial cancer have all the testing done by their oncologist or their surgeon. They get given the diagnosis of Lynch syndrome, but they then need to come to the genetics service. And the reason for that is for us to discuss the risks to that individual, not just of the cancer that they've got, but of the other potential cancers, and to ensure people go into what we would consider to be the appropriate screening programme. But then also to talk to them about the implications for other people in the family, so what testing we would offer, either to siblings or to parents or to children, and at what point we would do that. The other thing we now have is something called the National Inherited Cancer Predisposition Register, or NICPR. And this is essentially a big list of people in the population in England, doesn't apply to Scotland, sorry Glasgow, people who have gene changes in cancer predisposing genes. And the aim of this is, so it's used for Lynch syndrome as a way of getting people into the National Bowel Screening Programme. The aim of this is for the population with these gene changes in general. If there are national screening programmes that are available, this is the way that we will make sure we've got all the people into the right screening programme. But as I say, for Lynch, it's the way that we enter patients onto the screening programme. So this is the portal. This has to be done through the regional genetics services, so it can only be entered by people who work in regional genetics services. And you go into the portal to say this patient has got a gene change in this gene and they need to go into the National Bowel Screening Programme. We can enter patients onto the portal at any point of diagnosis. So irrespective of the age at which they're diagnosed, we will put them on, and then that system then flags when that person is the right age for colonoscopic screening, whether that's 25 or 35. That patient will then get invited for the screening. And again, I'm not going to go into this to too much detail because Terry will talk about this, But essentially, depending on which gene there is a fault, depends on the age at which you start colonoscopic screening. And then there's discussions about what sort of endometrial screening or risk reduction can be done. So as I say, all the bowel screening now is done under the National Bowel Screening Programme. And that took us a long time to achieve, but actually I think it now means that all patients with Lynch syndrome will have their colonoscopies at the set time spans. It's a robust system. It's got a really good recall system. And when we were establishing it, the sort of pathways we were talking about in terms of, if we've got a young woman coming in, what do we do if she's due a colonoscopy and she's pregnant? At what point does she then have to have a screening? Do we do it from the time at which we were going to do the screening? Do we do it at the time from when after the baby's delivered? All of these sort of nuances have been thought about in this screening programme. And the other advantage of this is that in order to be in the National Bowel Screening Programme, the people who do the screening have to have a very high level of competence. So we know that they've got a high rate of going all the way around the bowel. We know that they take enough time coming backwards from the bowel within screening. So we know that the National Bowel Screening is robust in terms of recall, and it is consistently a very high quality endoscopy, which clearly we need for people like you. Autosomal dominant inheritance. So essentially what this means is that if you think about any of these genes, anything that's autosomal dominant, if you say, for example, it's Lynch is due to an MLH1 gene change, everybody has 2 copies of those genes because you need them in order to have the normal development and the normal processes in the body. Mm-hmm. But if you have a fault in just one of those copies, that's when you have your predisposition to these cancers. And so if you've got 2 copies of MLH1, one's working, one's not, you will pass on one of those to each child. So each child therefore has a 1 in 2 or 50% chance of inheriting that gene change. That is random. It's like tossing a coin. So if someone has 4 children, it doesn't mean 2 will and 2 won't. It means that you might be lucky nobody has inherited it. You might be unlucky everybody's inherited it. More likely there will be a combination of people within the family. And I think that's really quite important to think about when you're also thinking about cascade testing. Cascade testing, predictive testing, pretty interchangeable terms. Essentially what that means is offering a test to a member of the family who does not have any phenotype, doesn't have any features of the condition. And you will offer that test in the regional genetic services. That's done from the age of 18. You often find that young individuals decide to leave testing until they're coming up to the age at which they would start colonoscopies. Has to be, and I apologise for this, but men are worse than women at trying to get this sorted. And one of the things we talk to people about is, actually whether having a test will be something that causes more anxiety than not, whether people will cope thinking that they've got a potential risk of something which is, timescales which are unpredictable, but we need to put them into screening programmes, and also timing of the test. So actually, if an 18-year-old is about to go to university, is that the best time? Should we wait until we know where they're settled in the country? Should they have finished their degree? Because actually where they're going to end up living may not be where they're currently living. Are they thinking about families? All of that sort of stuff. And then also thinking about how an individual will cope if we're talking to them about having inherited a gene change and they've got children, how much their anxiety about their children will impact on their decision to take a test. At what point do they start talking to children, rather than saying, on your 18th birthday, there's this in the family, we need to think about it, how to sort of bring that up in general conversation. And also just thinking about, as I said, if you've got a SIB-ship of people going through testing at the same time, traditionally we don't offer tests to SIBs at the same time, because actually that can be quite hard to get the results of 2 people at once, especially if they're going to be different. It's also quite important that people talk to each other about tests, about how they may feel about it. Some people in a family where there's Lynch syndrome who don't have it find that quite hard to deal with. So it's all these discussions we'll have with people when they're thinking about genetic testing. And I think the last thing I really want to say is that, actually everybody who's got Lynch syndrome is under the care of a regional genetic service. If you've got any issues, if you want to talk about anything, then you should be able to contact your regional genetic service. And we'll have touch points at which we try and keep touch with families. So You know, when you're thinking about patients going into screening programs, when people are thinking about reproduction, when you're thinking that children are coming to the age at which genetic testing might be appropriate. But you have the ability to contact your local service and ask for a review appointment if you've got something you want to talk about, if you want to talk about any of those issues. And say there's 20 across the UK, and you should be aligned with one of those services. So if you've got any queries, then you just need to contact your local service. That's what we're here for. I was going to stop there. Has anybody got any questions?
Thank you very much. Perfect timing. Any questions for Fiona? Yeah.
I'm interested in breast cancer because it's been querying whether Lynch, and I've had bowel cancer and endometrial cancer and spread to my liver, which was dealt with. But then a few years later, I had breast cancer, and it was very small. It was caught on a mammogram.
It's a regular question. In fact, Karen was harassing me in the bar last night on the exact same subject. So, Fiona, is there a problem with breast cancer?
So I think the original studies suggested there might be, the latter studies suggested there probably hasn't. And one of the difficulties is if you have a really common cancer, which breast cancer is, you will often see them in families, but I don't think the evidence around that is substantial, actually.
And there's been a lot of stuff. I mean, Ian Frayling couldn't be with us this time, but I'll be talking at the end of the day about our analysis of Lynch syndrome cancers, and one of the questions was, is breast cancer one of the list? And Ian, who many of you will know, has spent all his life working on this, said it's not. He's very determined to say it's not our Lynch syndrome cancer. And as Fiona says, it's just, it's such a common cancer, it's hard to separate. Even doing our tests on it, because if you've got Lynch syndrome and you get the breast cancer, you might get some changes in the tumour as it's growing in the mismatch repair genes just by accident, so it's very hard to actually prove it. But the best evidence comes from UK Biobank and the prospective database, where there is no excess.
I'm just thinking if I was to get metastases from breast cancer, would they be...
That's a more complicated question.
Yes.
We can't address that. But yeah, I mean, I think your Lynch syndrome needs to be taken into account. Yeah. It's a tricky one, but I think we're confident that it's...
Perhaps next year we'll know.
Yeah, sorry, yeah.
Can I ask the same question about pancreatic cancers?
So again, there is evidence that some pancreatic cancers are associated, and there is an increased risk. I think the absolute risk is difficult to get the information about. And I think there has been some suggestion that some of the checkpoint inhibitors could be used in the situation of pancreatic cancer.
That's a maybe.
You're saying there's a space between testing between siblings. So I mean, my daughter now, she's just gone being tested for it.
Hello, John, can you hear us?
Yes, sorry, go ahead.
Testing for
Hi,
it.
good morning,
Well, we need to use the microphone, or Glasgow can't hear what to say. Sorry about that, guys.
Yeah, what is the distance between one child having the testing to the other one having a testing?
So obviously, if it's a family you know about, then the age difference is because when they hit age of 18. If it's a family who are coming forward, I personally would leave it a month or so. So we're not talking about years, but we are talking just to try and get, for the family to get your head around one result before you have to think about another one, essentially.
Are there any questions from Glasgow?
Yes, we do.
Shoot.
Just get the buttons.
Repeat the question.
I haven't heard yet.
No, we haven't asked.
That's really.
Okay. Hi, thank you. Just in terms of when we get our kids screened, I know you mentioned when they become adults, is there sort of an optimal time in terms of them knowing so they can start taking precautions and undergo screening for both boys and girls?
So we would offer testing from 18. Clearly, if you've got a family where screening starts at 25 because you've got a mutation in MLH1 or MSH2, then you'd think probably knowing that before the age at which you enter the screening is sensible. And equally, you could leave it till 35 if you've got MSH6 or PMS2 in the family. But often the timing of testing is very personal. We can have conversations, but people don't have to have tests at set periods. It depends on what's going on in that individual's life, but ideally before they're due to enter the screening programme.
Okay, one last question and then we'll move on. Yeah.
One last comment on that. That sounds like a great theory, but my experience with my children is that they've had to wait 9 to 15 months for their screening. So this planning just goes out the window.
For the screening or for the testing?
For the testing.
One of the issues we are dealing with at the moment is we have horribly long waiting lists in clinical genetic services. So if you are thinking that your child wants testing by 24, I would be getting referral at 23. So because we've got such long waiting lists, I'll be asking for referral about a year before you want to think about testing. We are, well, actually, Terry and I have just been discussing this. We were hopeful that might get better. The financial situation in the NHS is not looking grand, so I think the waiting lists will continue, sadly, to be quite long.
Thank you. As a retired but still active-ish clinical geneticist, the point is it was designed for dealing with rare diseases in relatively small numbers, and we've got 20 services for 60-odd million people. And, so many tests are being done now that the service is getting inundated. What we're trying to do is offload a lot of the original testing into what we call mainstreaming, so that all the other doctors get involved as well, rather than just geneticists, because we can't do it.
I think the other thing also depends on your service. So if you're referred into Manchester, it's not a year, we've got a 6-month prioritisation, but we have prioritisation processes for different aspects of genetic testing.
We've got
So,
one very, very last question.
Very, very quickly. Can you pay for the testing? My daughter's nearly 15, she's had genetic counselling, they've approved her and said she's of a mature mind, but they cannot pass the barrier, but it's got to be 18. She wanted testing since she was 10 years old. Can you pay privately to testing?
you can pay privately. There are a number of private genetic services. I have to say, I think it's not a hard and fast rule about 18. I would
always told 16 growing up, and
Yeah.
sort of changed the goalpost to 18, and that's a good thing. She's going counselling because of her anxiety, not
Yeah.
not knowing.
So, I think I would go back and just have another conversation. Certainly, as I say, these are sort of generalised rules just because of the sort of the experience collectively we have as a profession, but there are always cases that sometimes need to be break the rules.
Hi, John, sorry,
Yeah, good
one
question.
question.
Yeah,
I have one question. Here we go.
go ahead.
Hi there. I was just wondering if there are any plans in Scotland to roll out the national screening programme.
The National Bell Screening Programme in Scotland starts at the age of 50. Currently, we don't have any set plans for Lynch syndrome or indeed patients with another inheritable condition. We don't have plans. It is something that we are looking at, following on from the success of the programme in England. So thank you, Anne. Thanks, John.
Okay, yes, so we can't legislate for the different evolved nations, which is an issue, as you realise. Okay, we're going to move on now. Thank you very much, Fiona.